Hello, and welcome to a very special briefcase that is part of the series I am leading on diversity, equity, and inclusivity with CME Outfitters. Today's CMEO briefcase is entitled Joint Health Care, Real-World Tactics to Address Health Inequities. Today's program is supported by an educational grant from Johnson & Johnson. I'm Dr. Monica Peak, and I'm the Ellen H. Block Professor of Medicine in the section of General Internal Medicine, and I'm also the Associate Director of the Chicago Center for Diabetes Translation Research. I'm the Director of Research for the McLean Center of Clinical Medical Ethics, all here at the University of Chicago in Chicago, Illinois. I am really delighted to be joined today by my distinguished colleague, Dr. Ide C. Brown. Ide, can you introduce yourself?
Hello, and thank you, Dr. Peak. I'm Dr. Ide Brown, and I'm an attending orthopedic surgeon at New York City Health and Hospital's Harlem Hospital. I am an assistant clinical professor in the Department of Orthopedic Surgery at Mount Sinai Health System. In addition, I am the founder and president of Black Women Orthopedic Surgeons here in New York.
Ide, I am so honored to have you joining us today with all of your various hats that you wear. You're so busy. Thank you for making time for us. I'm really excited about our discussion. Our first learning objective for today is to identify the impact of health inequities on patients with joint health concerns. And I want to remind our audience that this CMEO briefcase is a continuation of our initiative to address unconscious bias, health disparities, and racial inequities. We're building a comprehensive library of educational activities addressing these important issues, and today's activity continues the discussion in joint health care. On this slide are the titles of the activities in the series with links to each of them. To view any of these programs, simply click on the activity title. If you participate in at least 3 of the programs in our D&I Hub, you will also be eligible to receive a digital badge demonstrating your commitment to education on diversity, equity, and inclusivity. Before we jump into today's program, let's gauge our baseline understanding of disparities in joint health. Which of the following do you think is true regarding joint health disparities in the United States? As we begin to address joint health care disparities, I do want to review some foundational points regarding historical racism that remind us how we all got here. We've done previous programs that cover these topics in depth, and those programs can be found in our D&I Hub. We have a groundwater issue, and I encourage everyone to participate in our foundational programs so we can learn and do better. But what I want to start out with is just acknowledging that there's the existence of systemic or structural racism that affects so many things, such as the disproportionate distribution of the negative social determinants of health, like food insecurity, unstable housing, transportation barriers, etc. Also low educational opportunities, poverty, and crime. In addition, the structural racism and interpersonal racism affect healthcare provider bias within the healthcare system. And finally, structural racism determines not only what is happening inside the healthcare system, but within communities, it determines who is exposed to things within the social inbuilt environment, such as toxins and various pollutants, which we know have direct impacts on health. So that all of these things cause indirect effects of systemic and structural racism, such that we begin to see things like differential care that's being delivered based on race or deviations from standards of care. We begin to see elevations of stress levels for patients who are being exposed to racism that we know causes pathophysiologic changes and epigenetic changes that impacts their health negatively. We begin to see increased rates of mental health disorders such as anxiety, depression, and PTSD. And in the long term, we see things that cause distrust of the healthcare system, lower retention in care, and things that make it more difficult for marginalized populations to continue to receive the kind of care that they need in order to stay healthy. And so this is the backdrop or the context for which we are then going to be discussing any of the very specific clinical topics that we do on any given occasion. And today, that is going to be joint health disparities. So Ide, what I just discussed is applicable to many, if not most specialties. And so can you go into some of the specific disparities that's seen with joint health?
So in reference to joint health, we really are speaking about disabling osteoarthritis, in particular, say knee and hip osteoarthritis. Now, there's a similar prevalence of osteoarthritis within Black, Hispanic, and non-Hispanic white patients. However, there is a disparity in the amount or the number of African Americans and Latinos, as well as indigenous populations, access and obtain these total joints. So it's been proven that 35%, there's a 35% longer wait between the first consultation with, say, a primary care doctor and a joint replacement for Black patients. There's overall a lower rate of joint replacements in Black patients. And you can combine that when we start to talk about social determinants of health, that if patients have, say, commercial insurance versus something like Medicaid, those who have the quote unquote better, more commercial insurance will most likely be able to see an orthopedic surgeon and have their care delivered effectively.
Absolutely. Thank you for that insight. We're going to switch gears to talk about a patient, but before we do, we're going to go back to that audience response question one more time and see if we can get more of the questions right. So we're going to ask it again now. Which of the following do you think is true regarding joint health disparities in the United States? So now let's jump into our patient case. Ide, can you tell us about Mary?
So Mary is a 52-year-old Indigenous or Native American female with chronic right hip osteoarthritis. Her past medical history is notable for hypertension and postpartum depression. Her BMI is 32.3. Now, Mary has previously seen several clinicians for this severe right hip pain, and looking through her chart, clinical notes state that she is difficult and non-compliant. So that's already one thing to look at in terms of how we're labeling this patient. Note that the patient, Mary, does not work. She receives disability benefits secondary to her hip pain and limited mobility. Mary also isolates herself from her family because she feels that she cannot contribute, again, due to her hip pain, and that she's unable to contribute in the house in terms of working in the home, outside of the home, cook or help with chores without having significant pain over the next several days. Mary has tried several creams and herbal remedies with little or no relief. She's occasionally used acetaminophen, but has not used NSAIDs. There has not been a trial of physical therapy or a home exercise regimen. And Mary, at this point, is not interested in having surgery because a family member had struggled with addiction following surgery. Quote, "I just want to feel better so I can work. I don't have time to drive here for appointments every week." And she misses cooking and working around the house and the yard, really participating with her family. So just a few things to highlight for her. Number one is this label of a difficult and non-compliant patient. Sometimes those labels are applied to people of color more than non-people of color. And the question is, what has made her difficult? What's made her non-compliant? It could just be a reflection that it's difficult for her to get to appointments, as she's pointing out lower in this slide. The other issues were that she's on disability because of this hip pain and all the impact of that financially, but also that she's unable to contribute in her home. So there's a psychological impact as well.
Yes, absolutely. When there are so many additional burdens that poor people carry just to sort of get through the day, most people who aren't having to experience those things don't even know they exist. And so don't realize how difficult it may be to even get to the doctor. Taking 3 buses, having to arrange for a ride when you don't have a car, who's going to help you pay for gas, all of these things that have to be sort of coordinated. Have to wait until so-and-so gets off work, are they running late? And they can be challenges for people who have limited resources. And so like showing up late at the doctor's office just seems like, well, why didn't you just get in your car and drive here on time? And so that is a privilege that people who have all of these resources have no idea what life is like when you don't have those resources. And so it's easy for us to label them um, as 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 though it's patients are uninterested in their health, as opposed to they have a large stack of barriers to overcome when they finally do make it to their appointment.
You make such a great point, especially about late arrivals. Even when people have or patients have access to some social supports, such as Access-a-Ride or the ability to get a car service, that car service or Access-a-Ride may arrive much later than to have you arrive on time to your appointment. So it's, again, so important to really look at the reasoning behind their difficulty.
Absolutely. So many things in this case. All right. We've talked about some of her issues and social determinants of health. Let me ask our second polling question, which is, in what percentage of your patients do you screen for social determinants of health during visits or as part of your preoperative screening? So what we have discussed so far, I believe it's accurate to say that several social determinants of health may have impacted the care and treatment plan that Mary has previously received. Far too often, the responsibility is placed solely on the patient to raise and discuss life and societal factors that may be undermining the treatment and the outcomes. How can we do a better job of screening for these factors in our patients with joint health?
Well, we can use even the screening tool that's noted in our slide for these social determinants of health. One being, do you or your family worry about whether your food will run out and you won't be able to get more? Number two is, are you worried about losing your home, losing your housing, or are you already homeless? Are you currently having issues at home relative to bills, utilities such as heat, electric, natural gas, water? And number four, is there an issue with transportation? Has that kept you from making your medical appointments, going to work, or getting to things or activities that are needed for your daily living? Or are you worried that someone may hurt you or your family? And these are important when evaluating a patient with joint pain for multiple reasons. One is their diet, of course, their intake is important. You want to have a healthy diet, or if the patient has comorbidities. So if they have diabetes or high blood pressure or high cholesterol, those are all things that can impact their joint health, particularly their weight. Their home, are they domiciled? If they are domiciled, where do they live? Is that a stable home for them? It's very challenging to address your hip pain or knee pain if you're worried about where you're going to lay your head for that night. And then if you do have those items, if you do have a home, are you able to sustain that home? Are you able to be in your home and have heat and have electricity and have gas and have water? These are things that those with resources can very simply overlook, but those are all very key to someone being able to even come to an appointment or to follow a treatment plan. And that goes to transportation, which we discussed a little bit earlier. And then, of course, being concerned that someone in the family can hurt them.
Yes. And they're also, as you're mentioning, interrelated to the pain itself. People that are obese are more likely to develop osteoarthritis. People that have transportation issues may be doing more walking on that joint that is disproportionately affected. And so all of these things may be causing flare-ups or, exacerbating the very disease that they're coming to see you for.
Absolutely. And sometimes if a patient has to take those 3 buses, right, to get to the appointment, they are going to be significantly in more pain than they were when they first started. That may prevent them from wanting to come in the future or wanting to go to physical therapy. Right. So these do determine the way we can take best care of our patients.
One of the positive things is that we're seeing more and more screening tools that are being validated and getting shorter become available and for use in routine clinical practice. So, Ade, do you think it's realistic for orthopedic surgeons to screen for social determinants of health with their patients? And if so, are there key questions you focus on, and how does your care team do this in practice?
So I work in a city hospital. Most of these are asked before the patient sees us, they're screened. But often in our conversation, it's what type of work do you do? If you're not working, what do you do with your time? How did you get here? How could you get home? And really, when you start to talk about the treatment plan, really asking the patient where they're at, would you be able to make this or not? So that's able to really kind of go through the questions that are here on our slide about their housing situation, food, whether they live in a food desert or not, and if they have significant responsibilities in the home, so they may not be able to make their physical therapy appointments or other appointments, and if they have enough support to really allow them to go through a treatment plan.
I really like this slide because it tracks those 4 questions and how they relate to these 3 key issues of outcomes, procedure planning, and ability to follow up with care. That is huge. And I think that would be hugely motivating for everyone who's watching this, which brings us timely enough to revisit that audience response question. So now that you've seen this data, what percentage of your patients will you screen for social determinants of health during visits? Now that you may see how important it might be to sort of take the time to ask those 4 questions during visits or as part of the preoperative screening. So in addition to screening and assessing for social determinants of health, we should also provide and engage in culturally competent care. We know that Mary is an Indigenous Native American. Can you talk about how you provide culturally competent care and what you would consider specifically with Mary?
So the first thing is to meet the patient where they are. So
Amen.
to validate what other treatments she's used and even to ask more about them. Some patients use turmeric, for example.
Yes.
So again, just validating their current experience. And the second thing is to really speak to the patient while they're clothed. So in their original, the clothes that they came to the appointment in, because then you are able to relate to the patient. They can perceive that it's the same level. There's the same level of respect, and they have the dignity of having their clothes on. And of course, speaking to them and saying, all right, now that we've talked, I'm going to step out. If you can please put a gown on or shorts so that I can do the exam, and tell them what to expect. And yes, that's
really
culturally.
Like that you mentioned that, particularly as a surgeon, because sometimes people, when the nurse comes in, she wants the patient to be, undressed so that when the doctor comes, they're fully ready. So the doctor meets patients naked and vulnerable. So the idea of saying when they're fully clothed with all their dignity intact, when they feel like themselves, and to some degree, there's always going to be a power imbalance, but they can meet you eye to eye and feel like they can at least have that kind of equal conversation. I think that is a huge thing. Thank you for saying that.
It also builds trust, right? As a surgeon, absolutely. At some point, this patient, whether it's hip arthritis, knee arthritis, ankle arthritis, may need surgery. And yes, we're walking with this patient through their treatment course, but you need your patient to trust you. So that's how they participate in their care.
Yes. So I had interrupted you, but I just wanted to say.
Oh. So then just starting before even beginning the exam, making sure that the patient's comfortable with that. And even while performing the exam, to check in with them often. For example, for hip exam, you are examining the patient's hip. So this is, again, you're exposing near their genitalia. You need to internally and externally rotate their hip. They may be incredibly uncomfortable about that. So just checking with them and saying, okay, now we're going to range your hip. So being sure that you both are on the same page with what the next steps are. And really just, again, once you've established this trust, is to keep asking the patient, is this okay? Is that okay? So that they can progress through the exam and give you a true physical exam and leave the exam with some dignity.
Mm-hmm. Absolutely. And one of the things that I always try to do is have an extra sheet that's handy that is covering any body part that I'm not needing to expose at that time. Mm-hmm. And even if I can't get everything covered, the patient knows then I'm trying. You know, and I
Mhm.
think that the efforts that we make go a long way to establishing trust, even if we don't get there. You know, I think that that's more important than whether or not there's a little bit that's showing that they get that we're trying to respect their dignity.
Mhm.
Absolutely. So I can tell that you're just a wonderful clinician. I hope I never have any joint problems, but if I do, I'll
Thank
come
you.
to you. So with our patient case, it is clear that Mary is in need of better pain management. Mary's representative of patients that we see every day, that I see every day, and they, just like Mary, may be impacted by deeply rooted disparities in pain management. And that can be a whole talk in and of itself.
Mhm.
So Ide, what are some of the driving forces that are causing inequities and disparities in pain care?
Well, it's the belief that there's a higher incidence of opiate abuse within Black and Brown communities. And for that reason, there's a resistance within certain clinicians to prescribe appropriate pain medication. Also, historically, if even go back to I think it was Anushka, the early exams and the speculum that it's believed that Black and Brown people experience pain differently to such an extent that in the earlier medical history, we did not receive anesthesia for procedures that require anesthesia. So a lot of that is ingrained in our
Yeah.
dogma as clinicians, as in medicine, and just as surgeons. And that's a problem because that's your implicit bias, where you would see a patient and make these assumptions and then inappropriately treat their pain.
Yeah, they did a study not that long ago of medical students, and they're like, oh yeah, Black people have thicker skin and feel less pain. And who told you that? You know,
Exactly.
how is that still what? You know, so yeah, it's a challenge. It is a challenge.
And it creates this level of distrust, right? Patients, and there's some data that shows patients are more likely even to get their total joint replacements once they are part of this kind of care plan.
Mhm.
And part of that is them thinking that you want them to get better, right? That you are believing that they're in pain. You're believing these things, the limitations that they have, and then that you will work with them to make them better, not just the surgery, but their recovery from surgery.
Right.
And that's a challenge to do if you're carrying these implicit biases. But the first step is really to acknowledge that it exists, and then to work on, dismantling that.
Absolutely. Absolutely. So talk a little bit more about the lack of diversity in healthcare and what that might mean.
Well, multiple studies have shown that patients get better care if they're cared for by people that look like them. It may just be that level of trust, that shared experience. But there is a huge disparity in terms of particularly Black and Brown physicians of all types. And we can even speak about orthopedic surgery. There's 1.9% of all orthopedic surgeons in the United States are Black. It's about 575 people, literally 575 people.
You all could all fit in one room.
We have, I think, in our annual meeting. But that's an issue if the majority of orthopedic surgeons are overwhelmingly white and they are overwhelmingly male. 6% of orthopedic surgeons are female. I think the number is now going up if you count some of the recent grads to 12%, but that's still incredibly low given that our population is about 50-50. So those create challenges for patients because they're not going to have access to a clinician that looks like them. However, it's incumbent upon all of us, regardless of color, race, gender, ethnicity, for us to be sensitive to these issues so that we can still provide quality care.
Mm-hmm. Absolutely. So piggybacking off of this provider bias and the lackluster diversity in our healthcare system, Ade, can you explore the relationships between race, bias, and opioid misuse?
So we kind of hinted at this a little bit earlier, but this false biologic belief and superhumanization of Black bodies in our healthcare system, that is directly or correlates with undertreating or under-recognizing Black patients' pain. And that is a historical, even if you think about how, I mean, I know I mentioned OBGYN before, but just the concept that people are exaggerating their pain from horrible arthritis to get drugs, that all plays into this perception that Black and brown communities are at a higher risk of developing an addiction. And the Black patients are perceived as having a greater risk of opiate abuse or misuse than white patients, even though there's actual lower rates. And because of those implicit biases, there is a discrepancy in the prescription of opioid treatments in long term, but also in terms of pain management for these simple musculoskeletal complaints. And it's really, it's unfortunate, and we all have to work incredibly hard at dismantling these biases so that we can take better care of our patients.
Absolutely, absolutely. So let's go back to our patient, Mary, who has chronic osteoarthritis in her right hip. What are some of the non-surgical interventions to manage her osteoarthritis?
So really, it's important to coach to patients that surgery is the end treatment. We want to partner with patients and help them manage this complaint until these treatments no longer work. It starts as minimally invasive, as them taking a medication or applying a topical anti-inflammatory cream. So your non-steroidal anti-inflammatories, ibuprofen, naproxen, meloxicam. Once those aren't as helpful, and patients can try their different herbal medications, if that's part of their culture and something that they have found to be helpful. We then start to walk along with things a little bit more invasive. So that's where you talk about an intra-articular injection. We can inject the joint with a corticosteroid, we can inject it with stem cells, we can inject it with platelet-rich plasma, hyaluronic acid. A mix of two has shown to have good results as well. And these can all be paired with, alternative therapies. And that's your Ayurvedic therapy, your homeopathy, and even thinking about what patients are eating, right? Their intake, using foods that are low in inflammatory mediators. And some patients do find relief just with supplements such as glucosamine or chondroitin or certain vitamins. And a big part of what in my practice is sending patients to physical therapy.
Yes.
Really strengthening the muscles around the joint as well as the core can greatly diminish the pain that they're feeling, using things such as a knee brace. And then we can progress more in terms of our invasive management, whether it's laser assisted chondrogenesis, or then we really start to talk about surgical management depending on the type of arthritis. And that can range from things where we just stimulate cartilage healing within a certain part of the bone to, and that's minimally invasive, to something such as a total knee replacement. Yeah.
I have found that my patients love the joint injections once they get past the idea of a long, skinny needle, because they are so effective, and it gives them several months of being pain-free to be able to exercise and to try and lose some of the weight that is sort of perpetuating that cycle. Like I want to lose weight, but I can't move because of this pain. And so like, if I can, like, how am I supposed to, like, what am I going to do here? And so,
right.
Yeah.
The patients leave with a sheet of paper that says lose weight, go to physical therapy, take these medications, and see you in 6 months. How do they actually implement that? Right. And that goes back to social determinants of health. What food do they have access to? Are they in food deserts? Right. What transportation do they have? So it's, but joint injections are something that I use in my practice significantly because it does provide some immediate relief for the patient. And then once that steroid kicks in, more prolonged response, more prolonged help.
Yes. Thank you for detailing some of those options for us. Now, as fantastic as it is to have an array of non-surgical options to manage osteoarthritis, that doesn't mean that that array is applicable or possible for all patients. So how do we go about personalizing care for racial and ethnic underserved patients?
One is recognizing what biases exist in medicine. So thinking about the misperception of pain, or that patients have had poor access to pain management. So that's where you would just reintroduce the idea of the more conservative measures and be sure that they've used those conservative measures. Also just thinking about any language barriers or cultural barriers. What if you prescribe physical therapy, but the place closest to the patient's home is all men and they don't, if it's a female patient and she doesn't want to be treated by a man, then you've eliminated an entire really powerful treatment for this patient. So it's important, again, to meet patients where they are. And when we make these recommendations, talk about, well, how would you get there? How do you get to physical therapy? How would you get home? How would you pick up that medication? Is it easy for you to be able to change your diet and decrease certain certain high fat foods? And another thing really fortunate from the pandemic is that we really think about telehealth, that
Yes.
patients can have physical therapy right online. And that's really important because now you're eliminating these barriers to care, whether it's that they can get the transportation or not, or if they're having so much discomfort that isn't well treated that they can't get to therapy or move. So that's important, but then you have to think about, do they have the internet? Do they have access to consistent internet? So social determinants, all of these, you really, again, have to take the patient in their entirety and know their experience and validate that experience and partner with them on how to take the best care of them. And then it's very important to share to the patient that you both share the goal that you do not want them to become addicted to an opiate, right? You do not want them to become dependent on opiates. And that we, particularly in orthopedic surgery, have made a lot of strides in using a multimodal pain care to really diminish the use of opiates to a very, very small window. And acetaminophen being something that we even use IV intraoperatively to help patients in their recovery from total joint replacements.
I didn't even know that that was possible.
Mm-hmm.
What I learned today. I'm trying to learn one new thing. Check that out. So, there was interesting, like there was a clinic, I worked with various kinds of FQHCs over the years, and one of them took over a space, I don't know what it used to be, but they have a gym that's on site. And so they have all kind of, classes that are available. And so they could, pipe in this physical therapy that people could come, to the clinic and, get their physical therapy there as opposed to, wherever that was. And so I think there are a lot of creative ways when the community comes together. And that's what addressing these social determinants is about. It's like how we have to, it takes a village, putting all the pieces together to work for a certain person, to work for a certain population. What are the assets in this community and how can we piece them together to make this thing work? So yeah, it's very fascinating. Thank you so much for all of your insight.
I mean, I often say to my, I often say to my, whether it's the mid-level practitioners that are helping or trainees, what would you do for your loved one? For me, it's what would you do for your grandmother?
That's right.
How would you, and once you change that lens, it enables them to give more equitable care. But sometimes you have to personalize it for that provider so that they can begin to see the patient differently.
Yeah. I remember when my grandmother, when she was still living, she used the bank as her personal Kinkos. So she would go to the bank and they would like fax stuff to me and all this stuff. And I'm like, come on, but they just loved her so much. She was so sweet. And I was like, what is happening here? But that's
right.
They knew she didn't know nothing about none of that other stuff. And so she was always going to the bank. Like, no, who pays with checks anymore? My grandmother was always paying with checks and all that. So she was always in the bank and honey, can you just fax this to my granddaughter, and and so it's that sort of loving approach and like seeing people's humanity, seeing them in need and realizing that they may not have the resources, the wherewithal to get this done, but you do. And it may not really be your job.
Mhm.
Can you just lean into it a little bit more and make this happen? And that's what it takes. So yeah,
Yeah. For
all
these
right.
abuelitas, so grandmothers. Here, I live in Harlem and work in Harlem, and rather than have a walker, they'll push a grocery cart, the little shopping cart,
Mhm.
because it's more modest. You don't seem as old if you're walking with a cane or you're
Yes.
walking with a walker. But if you just push your cart as if you're going to and from the grocery store, you're still able to get out and about, but without necessarily kind of
Right.
labeling yourself as someone who's becoming disabled.
Yeah. Yeah. So much, so much. But we're going to have to move on to our second learning objective for today, which is to individualize treatment strategies that include assessment of social determinants of health for optimal outcomes in patients with joint pain. So we're going to go back to Mary and learn more about her so that we can discuss how you would develop a treatment plan for her.
So now looking at Mary, she's not in any distress. She does seem to have a flexion contracture of the right hip. So the physical exam for most orthopedic patients actually starts with them walking in the room. You see their gait. With advanced hip arthritis and the fact that she's been in so much pain, she would have an antalgic gait, right, where she's favoring the less painful leg. You would look at the spine, and she has a normal spine exam. And again, just remembering that someone can have lumbar spine complaints that mirrored as hip pain and vice versa. So it's important to examine both. And then when we see her right hip exam, she's noticed to have, she's unable to really adduct or internally rotate. There's pain with the attempts of that. And she has pain with external rotation. And when you're doing that part of the exam, it's really important to be very gentle, because you can feel sometimes the crepitance, right? So you're feeling that inflammation in the hip, and that's incredibly uncomfortable to the patient. So you want to kind of just do that once, and then, but you need to be able to assess their range. You look at the rest of the body, the extremity, and note that there's no other numbness or tingling on that side. And again, we spoke a little bit about the gait itself, where that patient's going to have this antalgic gait, going to be walking in a slower pace, have a shortened stance phase on the affected hip, and that she's not using an assisted device. When we look at her imaging, and so this is normally when I can step out of the room, is I'll go look at the imaging after actually talking to the patient, step out of the room, look at their imaging, then come back and examine them. That gives them the time to change. So then when looking at the imaging, the patient's x-rays of both the lumbar spine and the hip, that she has some moderate osteoarthritic changes of the hip, which means that the joint space is more narrow, that there's osteophyte formation, there's even some cysts, but the other hip as well as the lumbar spine aren't really significant. I mean, there's some mild degenerative changes in the lumbar spine at that L2, L3 level. So with all of that information, how do we create a treatment plan that Mary can be a part of, and how do we partner with her in this plan? So, first is to say, what do you currently use for pain control? She was using some non-steroidal anti-inflammatories as well as some herbal remedies. Did that work, or did it stop working? And just being careful to be mindful that the patient may or may not be very sensitive to the implicit bias in our field of medicine towards opiates and indigenous communities. And the other thing that's incredibly important is that her physical exam is coupled with what you see on your imaging. There are some patients, I have had patients actually run marathons with pretty horrible knee arthritis. If you just saw their knee films, you would think that they need a total knee replacement, but you see them walk in and they just ran a marathon. So you have to take the clinical picture, so what the patient actually looks like, together with what their radiographic findings are. And note that for a good amount of time, that conservative non-operative therapies help. And again, with this discussion, you have to consider these social determinants of health. How does Mary get to and from physical therapy? How does she get to the pharmacy to get her medication? Does she need more social supports to help at the home? And is there a social work consult that needs to happen there? So really, you want to partner, and that partner is the important word there, with your patient so that they can participate in what your suggested treatment plan is. And it's also important not to have these preconceived biases about what other complementary treatments, whether it's Ayurvedic therapy or whether it's certain herbal remedies or it's a low inflammatory diet. All of those elements are, if the patient's using them, those are therapies that they respect, and you as a clinician need to respect that as well.
I have a question. I would assume that if someone had just run a marathon and had horrible x-rays, my tendency would be like, oh my gosh, you need to have a knee replacement because we need to get you back to running, as opposed to, well, you seem to be doing fine. So which one is it?
Well, they're not going to really run marathons on a total knee. They'll wear them out pretty more quickly. But I think the point where you would start to suggest the surgery would be if they're no longer able, of course, to run that marathon, or they're starting to get deformity, which would make it a much more complicated procedure.
Interesting. Huh. I've learned two things. This is great for me.
Okay. It goes back to pain tolerance, right? It's like some patients' pain tolerance is different, and so you have to partner.
Yes. Okay. So let's talk about patients who may be candidates for hip replacement surgery. Are there factors that are specific to patients of color that may impact their decision-making in regard to arthroplasty?
Well, it's really looking at the comorbidities. So as we pointed earlier in this presentation, that Black and brown patients actually present later with more advanced disease because they are referred at a later time for these. So they may present with more comorbidities, making their perioperative course more difficult. And patients, of course, are interviewing surgeons depending on their area as well. It's also important to, again, partner with the patient where they are. So is this a patient that would want to have, a faith worker, whether it's a priest or a natural healer around, who's in their social network that can help them go home? Will they need to go home? Will they need to go to a rehab facility? And walking them through through their recovery process. Our American Academy of Orthopedic Surgeons actually has a small video on arthritis, as well as on different knee or hip replacements. And if it's in the proper language, that's helpful for the patient as well. And that all allows you're setting your patient up and yourself up for the patient to have the best recovery they can have. But you really, again, have to view them. We're surgeons, we love to do surgery, but our outcomes are impacted on how the patient's able to comply, how the patient's able to follow what our postoperative recommendations are. So you do want to optimize them preoperatively, right? If you can get their blood glucose, if you can get their sugars under better control, or if they can lose some weight so that they have a lower risk with surgery. But ultimately, postoperatively, it's very, very incumbent upon the surgeon to tailor the plan with the patient.
Absolutely. Absolutely. That's when you're going to get the best outcomes, when that patient and the clinician are on board with what's actually going to happen. I do a lot of work in shared decision making, so I say that all the time. Okay, so I think that often as clinicians, we do things in our practice that are based on, medical voodoo, like the way things just normally are, implicit bias, and not necessarily evidence-based medicine. So we're going to take a moment for another audience response question. And the question is, what strategy do you think healthcare institutions could use to most effectively reduce bias in pain management? So let's talk a bit about how we can provide more equitable pain care. Ade, what can you tell us about that?
Well, of course, the first thing is to be aware of these biases, and that happens by using tools such as this video, doing education to healthcare providers so that they understand really that scientific history, right? The scientific racism that occurs within the Black community. And now that they are aware that we can start to tackle that and dismantle that, identify that bias. It's incredibly important to respect the history of Black and Brown communities in health. And that with that, patients can have an apprehension about interfacing with the healthcare environment. And that is a problem, right? Because if you interact with the physician who's unaware of these biases, they can traumatize the patient. So it's not just that, X study happened and people were tested or given, diseases without their consent. It's an ongoing active process because structural racism exists. It's structural, and patients are experiencing that in different ways. And again, we need to partner with those patients in order to have them really be a part of that care, especially with pain management. Note that people have different interpretations of pain. So, we just talked about a patient that ran a marathon with horrible knee arthritis. That patient, someone else can come in with not that bad knee arthritis that's really having crippling pain, and know that that patient should be treated differently than the one that just ran the marathon, right? That may be one that you're going to kind of go through and think about more invasive, even such as a joint injection. We are in a world where there's evidence-based medicine, right? It's not the science voodoo from way back in the day where people just kind of thought of things and wrote it down. We are able to actually use evidence to see how patients are experiencing pain, and we have techniques and multimodal processes that can help them improve their pain. And it's really important to use those validated guidelines for the pain protocols or checklists so that we can be sure to treat patients for pain and not under-treat them. And of course, there's a continuation of a collection of data for this in terms of pain management in communities of color.
Excellent, excellent. So we're going to go back to our polling question. So now I'm going to ask again, what strategy do you think healthcare institutions could use to most effectively reduce bias in pain management? So Ade, let's individualize the treatment plan for Mary. Can you tell us how you treated Mary?
So treated Mary by giving her acetaminophen, anywhere from 650 to 1,000 milligrams, encouraging her to walk more, right? And that some weight loss as well. And Mary, on the 60-day follow-up visit, she is feeling better. She's able to start cooking again. She feels more valued at home. She's able to contribute. And although she has hip pain, it's not as limiting as it was before. So Mary is doing well with our treatment plan. And given that she's having less pain, she will move more and she'll probably continue to lose weight. So these are all positives for her.
One thing I'll also say that I've seen is that association between pain and mood. And so when people feel better about life and themselves, they seem to have less pain. You know what I'm saying? They're less attuned to the pain that they're having, and they're able to sort of push past the pain that exists. And so for this patient case, when she's able to sort of be back to herself, doing the things that she loves, feeling more engaged in her family, that's a patient that I would say, would be having less pain, even if she wasn't taking the Tylenol. You know what I'm saying?
Mm-hmm, mm-hmm.
Anyway.
Yeah, there's that psychological component. If you're in this multi-generational family and you really love to cook and you can't do that, that's going to have an impact on you psychologically. Yeah. And that, of course, would impact your pain as well. So I would agree. It may not even be the Tylenol. It's this all of the treatment together.
Yes.
Entirely.
Yeah. Which gets back to this idea of thinking about people holistically. in their full humanity and all the things that we can, think about in our toolkit to help take care of them. So in maintaining cultural competence, we can better connect with our patients and have conversations with them to determine the best treatment options for them. So Ida, how did you discuss treatment options with Mary, and what patient education tools do you use in practice that are culturally competent?
Well, again, meeting the patient where they are. What are you currently using? What do you have access to? Being able to increase or change or combine those over-the-counter agents. Speaking to her about more movement and letting her know that the more weight you lose, that's less weight, that's less force on your joint, which can make you feel better. And really asking what are her hindrances to doing more walking, right? Beyond just the hip pain. Asking if she wants to continue with her current medications, or if she's at a point where she wants to try something a bit more invasive, so something like an injection. And if those have all failed, that's where we really start to talk about things such as a hip replacement. And again, patient education and partnering with patients is incredibly important. The American Academy of Orthopedic Surgeons, which is orthoinfo.org, has wonderful videos and articles in English and Spanish on both exercise programs for home with photos and little diagrams. And those are things that can help a patient if they're unable to actually get to a physical therapist due to insurance or due to transportation or due to other barriers.
Excellent. This was such a wonderful discussion. I learned so much, including those two things that I had no idea about. IV Tylenol, who knew? And I feel like we learned some great clinical pearls that we can use to provide more culturally competent care for our patients with pain. So let me summarize our discussion with SMART goals, which I want you to sort of let me know where I may have left out. And SMART goals are those that are specific, measurable, attainable, relevant, and timely. So that's what I hope you will take from this presentation and apply to your practice for everyone in the audience. And so those were to identify inequitable processes and pathways in the prevalence, treatment, and pathophysiology of joint care in minority populations, and change outdated pathways or processes immediately. 2, incorporate solutions to address racial and ethnic disparities in joint disease diagnosis and management, as well as access to care. 3, integrate simple tools that provide more culturally competent and empathetic care, which can be as simple as sitting down, looking the patient in the eye with their clothes on, and asking about their goals. And last, develop personalized treatment plans for the management of patients with joint disease, with considerations for social determinants of health and patient preferences. Anything I've left out?
No, I think you got them all.
All right. Well, here are just some of the topics we've covered so far, and we will be adding new content every month. CME Outfitters also has a diversity and inclusion hub with a number of excellent resources to share with your peers and your patients. To receive credit for today's activity, please complete the post-test and evaluation online. You can then download your certificate immediately. Thank you again, Ida, for joining me, and thank you to our audience for joining us. Be safe and take care of yourselves so you can provide the best care to your patients, and especially our underserved patients.
Thank you.